thank you all so much for joining me today. It's a pleasure to be able to do this webinar. I know everybody's hyper focused on the existing and current pandemic, but ultimately, the thing that is the biggest danger to all of us in this population is chronic illness. And in fact, that kind of chronic illness also increases susceptibility to adverse reactions to the current pandemic. So this is still incredibly relevant, and I want to thank you guys for joining us, for those of you that are here live, as well as anyone else that will be watching this afterwards. The two housekeeping things is, yes, this recording will be provided afterwards, and then the second thing is, there's a likelihood we may not end up having time for Q&A at the end, so if you could, please type in your questions into the chat box, and or the question section, which there is a specific question section. And what we'll do is we'll get all of those questions to us. We will type back responses to each of those and send them out to all of the registrants for this event. So we'll make sure to get questions answered one way or the other. A little bit of background on where this concept has come about and how we've developed this. You know, we've had the absolute pleasure of working with functional medicine, naturopathic medicine, doctors and practitioners over the last 7 years. We are obviously focused on the microbiome and the role of the microbiome in disease, and how do we modulate the microbiome in creating wellness. The most common question we get from doctors, practitioners alike is, how do I know exactly what's wrong with my patient's gut, especially as it refers to different conditions? You know, just looking at a hypothetical day, you've got, you know, sometime in the morning, the first patient that you see has anxiety and depression, and you know, because of your training and your background, that they have some gut component to it. There's some sort of dysbiosis going on that is either A, the primary cause, or at least B, driving the condition and not allowing the proper response to other therapies that you may be doing. Then the second patient that comes through your door, or in this case online, you know, is dealing with an autoimmune condition, and again, you know, there's something wrong with their gut. And then third patient is dealing with metabolic issues, diabetes, obesity. You also know that there's something wrong with their gut. Those are three very different conditions that present very differently, right? You've got autoimmune conditions, you've got anxiety, depression, you've got metabolic dysfunctions. You know that there's something wrong with each of their guts, and there's something you need to do to fix each of their guts. But the question is, how do you know what is wrong with the diabetic gut? How do you know what is wrong with the depression gut? How do you know what's wrong with the autoimmune gut? And if you can't pinpoint what's wrong, how do you go about fixing it? And that was the question that we set out to answer. You know, is there a way for us to understand what is wrong with each of these types of guts? And then, of course, extrapolate that to most of the main chronic illnesses that we tend to find. So, but what we found is that there is a significant amount of commonality in which we deem it to be the common dysfunctions of the standard American gut that are related to all of these seemingly unrelated diseases and conditions. So that's really the focus of what we're talking about. This is a journey through our last, you know, 3-4 years of investigation into the microbiome space, which also includes some of our own research that we've done on this topic. So let me jump in and share that with you. But that's the background on where this came from. So when we look at the gut, and we started looking at the gut as kind of the ground zero and trying to figure out what is going on at this ground zero that can lead to disease. And then the first thing that's important to acknowledge is the homeostatic condition of the gut, right? So let's look at what it looks like in a real general sense when there's homeostasis and things are functioning well. It's important to note, obviously, that we've got the intestinal epithelium. So this is your lining of intestinal cells. Embedded within the epithelium is a whole bona fide immune system, because within the epithelium, there's a set of L cells, M cells, Paneth cells, all of these immune cells that are extremely active in day-to-day immune response and function. So your intestinal epithelium is essentially a bona fide part of your immune system. And the intestinal epithelium, once you go past it, you are entering the basolateral circulation. Once you're in here, you are officially inside the body, right? So the intestinal epithelium is the last barrier before things are allowed to enter into the body, at which point they will end up getting a different type of immune response than before they enter into this part of the circulation. Now, the barrier that protects the intestinal epithelium is a mucosal barrier. The mucosal barrier, it's important to note, two distinct layers to the mucosal barrier. This is the mucin 2, the inner sanctum layer, and I'll talk about why I call it the inner sanctum, and then this is the mucin 1 layer. These have structural differences to a certain degree, meaning the mucin 2 layer tends to be a little bit more rigid, more firm. The mucin 1 layer is a little bit more liquid than the mucin 2 layer. And the mucin 2 layer is relatively sterile, meaning there are few microbes that exist in this area for the long term. Microbes do pass in and out of here. And of course, almost everything that enters the body through the oral and respiratory cavity will end up in this space and will pass through this mucin layer, which is where the immune system, the epithelium, the microbiome all sample what is entering into the body. So keep in mind that this mucosal layer is the largest sampling site in the body itself, right? So, but it has to be relatively sterile. It might be one of the only parts of the body that's relatively sterile. We used to think all kinds of different areas of the body was sterile, like our urine, for example. That was a thing I've heard, for years, that urine is sterile. Well, as it turns out, clearly it's not. Blood is not sterile. We've got about 1,000 bacteria cells per milliliter of blood. And of course, we have around 5,500 milliliters of blood. So we've got a lot of bacteria circulating around in our blood. Our cerebral spinal fluid is full of viruses and bacteria. Nothing in our body is sterile, with the exception of this inner sanctum that I say is relatively sterile, because there are some of these microbes that will move in and out of here, but it cannot have a high microbial load. If it does, then it causes a significant amount of immune dysfunctions, which we'll talk about. So having these distinct layers, keeping this area relatively sterile, and then the intestinal epithelium being a bona fide immune system, part of the immune system, has to have continuous crosstalk and communication with the microbes that exist up here. And again, a lot of things are sampled through this inner sanctum of the mucosa. The homeostatic state is represented by having high diversity in the microbiota up here and higher levels of protective strains called keystone strains. Again, we'll address those a little bit more in the upcoming slides, but that is a picture of homeostasis and proper function of the gut, proper function of the immune system, and thus the rest of the body. We need high production of postbiotics, especially critical ones like short chain fatty acids that maintain the structure. And then, of course, we need well-formed dynamic tight junctions, which allow for separation in the paracellular pathway to allow things like certain nutrients, larger size nutrients, to move through, but of course, staying closed to not allow non-specific transport through that paracellular pathway. Without the expression and the proper function of tight junctions, then you get literally open holes, gaps, if you will, in this intestinal epithelial barrier. So this is the homeostatic state. Now, what most Americans have is something like this, right? Now, it's important to note that this kind of disrupted state, and I'll talk through what this is, can exist in just a small section of the bowel. It's not that the bowel is either completely leaky or completely not leaky and sewed up shut. This is a dynamic state. So this can be happening from time to time, and it can be, and your body can resolve it, assuming you've got the right conditions. And I'll talk about what those conditions are. Now, this can also, if this remains as a long-term dysfunction, it can start off in just being in a few inches section of your intestine. And as this is allowed to progress and persist, it actually drives similar dysfunction in subsequent neighboring areas of the intestine. So for a long time, this kind of condition can remain subclinical. where you can't feel it, your patient doesn't have any symptomology of it, none of the related chronic illnesses are present. This is usually, when they're pretty young, they're in their early 20s, late teens, they're feeling pretty good. They may have sections of their bowel that are extremely leaky, but it is subclinical. It's not profound for them in any way, and their body deals with the endotoxemia. But the problem with it is this situation is setting up the foundation for chronic illness. Again, we'll talk about how all of that happens in a second. So one of the first things that leads to this type of disruption is something called dysbiosis, which you are all familiar with. And dysbiosis is really hard to define, because when you think about it, when it comes down to the species level, everybody has a different microbiome. Your species distribution is somewhat unique to you, right? And so if everyone's microbiome at the species level is relatively unique to one another, then how do you know what is a disrupted microbiome? And that's a big question that all of the microbiome research tries to answer. And so this term dysbiosis has to have some sort of definition. In our investigation of all the studies, it becomes clear that there are two main things that denote dysbiosis, and these two main things are pretty common across the board and can be defined for virtually anybody. Okay, so the first part of the definition of dysbiosis is having low keystone strains. In particular, some really well-established keystone strains like Akkermansia muciniphila, Faecalibacterium prausnitzii, Bifidobacterium longum, Bifidobacterium adolescentes. There's a Ruminococcus. There's a number of keystone strains. I think somewhere around 12 to 13 of different species have been, strains specifically, have been identified as having kind of keystone qualities. So what does that mean? Well, keystone strains tend to be extremely important for the overall structure and function of the microbiome. They seem to play a larger, more important role in the maintenance of the function and the structure of the microbiome. Many of them play an important role in maintaining a certain level of diversity within the microbiome, thereby controlling the ecosystem within the microbiome. A lot of them are also directly inversely correlated with disease states, and I'll show you some data on both Akkermansia and Faecalibacteria. So the loss of these protective keystone strains tends to result in a significant dysbiosis that can be directly correlated with disease risk. And so that's one of the definitions of dysbiosis. And note that the vast majority of these keystone strains are anaerobic strains that are found in the large bowel. And these strains tend to be sensitive to certain things, and especially things like poor diet. Many of them, like Faecalibacteria, Akkermansia, Bifidobacteria, they like resistant starches, they like oligosaccharides, they like different types of fibers that tend to feed these types of keystone strains. And of course, it's very common in Western populations to have much higher fat in your diet than you do fiber, and so that tends to have a disruptive effect in the presence of these keystone strains, and then on overall health as well. They're also susceptible to antibiotic effects. They're not predominant. They're not particularly robust organisms. So anytime the homeostatic environment in the gut is disrupted, they tend to suffer. So keystone strains are extremely important. One of the ways we can define dysbiosis. The second one is low levels of diversity. And a lot of times that is a result of having a reduction in keystone strains. We know diversity across the board over the last decade's worth of microbiome research has shown to be really paramount to overall health. And I'll show you a couple of studies on that as well. But diversity is absolutely critical. And we're talking about diversity in the gut microbiome. There are parts of the body where you don't want diversity. You actually don't want to see too much diversity on the skin microbiome. There should be a predominance of a couple of species that indicate wellness of the skin. You shouldn't see much diversity in the vaginal microbiome. The vaginal microbiome actually ends up being very close to a monoculture, which is a whole other topic of a great degree of interest for us. but we're talking about the gut microbiome, and the gut microbiome requires a significant amount of diversity to function properly. Now, when you have low keystone strains and then the subsequent low diversity, one of the first things that gets impacted is the ability to produce adequate amounts of postbiotics. Postbiotics are, of course, products that are produced by the microbiome that we don't produce ourselves, and many of them we can't really get from diet in any significant way, and they're all significant to our health. Some of the most well-studied postbiotics are, of course, low short-chain fatty acids, butyrate, propionate, acetate. There are 3 others, valerate, for example, but these are the ones that we'll focus on for this talk. And having low levels of short-chain fatty acids and other postbiotics is a measure of a dysfunction in the gut and can be correlated back to risk for a whole bunch of chronic illnesses. Now, what's interesting to note is some of these short-chain fatty acids and some of these keystone strains are directly responsible for maintaining the structure of this mucosa. You know, I mentioned that this mucin 2 layer should remain an inner sanctum, meaning relatively sterile to the rest of the body and certainly relatively sterile compared to the mucin 1 layer. One of the effects of having disrupted microbiota and having low levels of keystone strains and low diversity is you start to get aberrant growth of microbes in the microbiome that tend to eat away at this mucin 2 layer. They actually degrade the mucin layer, but they degrade it in a way that doesn't engage the replacement effect of the mucin 2 layer. So what you end up getting is a net degradation of this important mucin 2 layer. And what it needs to happen in order for the mucin 2 layer to continuously regenerate, because it is continuously regenerating, is you need stimuli from bacteria like Akkermansia. Akkermansia is one of those that can trigger a gene called the muc-T gene. The triggering of the muc-T gene allows goblet cells, like these green cells here on our intestinal epithelium, to produce that mucin 2 layer. Now, the fuel that the goblet cell needs in order to produce the mucin 2 layer is butyrate. So without adequate butyrate, it cannot produce enough mucin 2 to keep up with the needed recycling and reformation of this structure. Also, there are building blocks that are absolutely critical to the mucin 2 layer, which we'll talk about towards the end, but just keep that in mind. There's building blocks to make up the glycoproteins that make up the mucin 2 layer. Butyrate is required. Goblet cell activation is required. All of those things require keystone strains like Akkermansia, postbiotics like short-chain fatty acids in order to maintain this state. So if you're getting low Akkermansia, if you're getting low postbiotics, and you're getting an overgrowth of bacteria that will degrade the mucin 2 layer, what you end up with is a net degradation and thus translocation of microbes, particles, viruses, and so on that are in this mucin 1 layer into this inner sanctum. Now, the intestinal epithelium being a bona fide immune system, part of our immune system, the moment you get a rapid translocation or a high volume translocation of microbes, even if they're commensal microbes, into this inner sanctum layer, it triggers massive amounts of inflammation because of this disrupted mucosa. Remember, this mucosal part is the major sampling site for the immune system for everything that enters the body. So this part of the mucosa is disrupted and things are non-specifically translocating through. The immune response in the mucosa becomes significantly disrupted, meaning everything that enters in here gets an inflammatory response because the body is trying to protect itself, right? So if you think about it, with the intestinal epithelium being the last and final barrier before things are allowed to enter into the blood, the moment the intestinal epithelium reads that there's loads of microbes coming through, it is anticipating a septicemia or bacteremia. Right? And it's trying to protect us from a septicemia bacteremia. So it's going to throw everything it can at this problem. And what it throws is the inflammatory innate immune response. So you get massive recruitment of early actors, dendritic cells, macrophages, cytotoxic T cells, and so on. And everything that enters this space gets an inflammatory immune response. Another problem with that is the gut mucosa and the gut immune response is the central command center for immune responses throughout the rest of the body. There's something called a singular mucosal idea, where the mucosa in the gut acts as a central command, and what responses are going on in the gut gets translated to the rest of the body. So as you start getting food particles and environmental particles and all that entering in here, even your own commensal bacteria, and all of that is getting an inflammatory response, that triggers a similar systemic response anywhere else your body encounters those antigens. So then you start developing all kinds of food sensitivities where you didn't have it before. You may have been totally fine with certain dairy proteins and peptides in certain foods for most of your life, but then all of a sudden you start developing sensitivities to it. Why is that? Well, it's because it's those food-based antigens are translocating into this inner sanctum because of the disrupted mucin 2, and because it's in here, it's getting a significant immune response every time you eat it, and then that becomes a loss of tolerance. Now, all of this upregulation of inflammatory immune response, and this is indicated by an increase in things like MCP1 or interleukin 6 or interleukin 1 beta. These are all measurable increases when you start getting this infiltration into the inner sanctum and you're starting to get this profound and broad spectrum immune response against everything. You start to develop that type of sensitivity and response to everything that encounters the body. So this is why this becomes really important. I'll show you studies on this as well. Now, as this is allowed to happen for a prolonged period of time, the inflammatory response in itself in this inner sanctum starts to damage the intestinal epithelial cells. And remember, these cells are just a single cell layer. There aren't multiple cell layers here. So a single cell layer, which means if one of these cells is disrupted and not turned over in a good amount of time, you actually have a physical gap there in that barrier system, right? So things can just leak through into the basolateral circulation. So eventually it leads to dysfunction in the gut barrier. And then the dysfunction in the gut barrier allows a lot of translocation of things like LPS and other toxins and so on. Now, what was interesting, well, we went through and followed this pathophysiology that you see in a disrupted microbiome and disrupted gut, especially in the Western world. You start to also see that when you look at the review papers on the pathophysiology of various diseases, they all share this similarity, and that's what I'm going to show you next. And in the interest of time, I'm not going to show you all of the papers available, but I'm just going to give you a preview of some of the review papers or the meta-analysis papers to show you that there's a significant amount of science behind the idea that this same pathophysiology is present in a large variety of chronic illnesses, right? So let's start with the first type of disruption we talk about is disruption of the microbiota, the dysbiosis itself. Here's one review paper that was published in 2014 that highlights dysbiosis, and they go through and they conclude that the disruption of the gut microbiota has been implicated in many conditions, things like obesity, inflammatory bowel disease, irritable bowel syndrome, type 2 diabetes, colorectal cancer, and so on. They reference the evidence for all of this, and they talk about having gained a deeper understanding of the specific relationship between the microbiota and disease. They propose something called intelligent modulation of the dysbiosis within the microbiota, as that can become of significant interest and possibly extremely beneficial for human health. So alleviating all of these kinds of chronic illnesses by modulating the microbiome, by attenuating or alleviating the dysbiosis that we talk about. And they go through and talk about things like keystone strains and diversity and so on. So there's a lot of studies there that back up that dysbiosis, as we are talking about and defining it, is correlated with chronic illness. Here's another one that looks at just the diversity side alone. This is another review paper where they're looking at the dysbiosis associated with inflammatory bowel disease. And they concluded that the most consistent observation in IBD is reduced bacterial diversity, a decrease of Firmicutes and an increase of proteobacteria. So they see phylum level changes and family level changes as well within the microbiome, but that reduced diversity seems to be very consistent when they compare it to age-matched healthy cohorts that don't have the disease. So they talk about, again, therapies that correct this dysbiosis, and they highlight a number of trials, including fecal transplants and probiotics, seem to be very promising for IBD. So it's really clear, and there's a lot of data showing that dysbiosis, as we are talking about it, these low levels of keystone strains, low diversity, is significantly implicated in health disorders. And in fact, how long you live is going to be highly dependent on the diversity of your microbiome. And there's a number of studies on aging, longevity, and diversity of the microbiome. In fact, they show in this particular study looking at population in China, those that were over the age of 90 that had healthy outcomes actually showed a similar diversity to those in their 30s. And so if your diversity keeps decreasing over time, your risk for chronic illness and your ability to attain good, strong longevity is going to be attenuated quite significantly. So diversity, this dysbiosis, plays a really significant role. Then, of course, there's the keystone strains. I mentioned one of the indications of dysbiosis is the presence of keystone strains. Take Akkermansia, for example, and again, this is a review paper. They show that Akkermansia is inversely associated with obesity, diabetes, cardiometabolic disease, and low-grade inflammation. The higher Akkermansia you have, the more protected you are against all of these conditions. And as you guys all know, just these things that are mentioned here will kill 4 out of 5 Americans. Right? So these are very, very significant. And there's one strain in your microbiome, this keystone strain, that plays such an important role in protecting us against these dysfunctions. They also talk about how Akkermansia mucinophila is considered a novel potential candidate to improve metabolic disorders. And indeed, administration has been shown, and this is both in animals and humans, to profoundly reduce the development of these diseases. In fact, there are engraftment studies in animals, and there are some studies in humans as well that show that by increasing Akkermansia levels, you can actually reverse the process of development of diabetes. That's how profound it is. And as you guys know, diabetes is the next health pandemic that we're dealing with, because the number of diabetics in the world, and then even scarier than that is the number of pre-diabetics in the world, which is 4 times larger than the number of diabetics. It becomes a significant impact on our overall healthcare costs and outcomes. We also know another keystone strain, Faecalibacter prausnitzii. This review article again went through the research, and they find that the abundance of F. prausnitzii was decreased in IBD patients compared with healthy. And they talk about how this meta-analysis and systemic review suggests the possible protective benefits of F. prausnitzii in IBD, and any sort of prebiotic or probiotic that can increase levels of F. prausnitzii really could be beneficial in the case of inflammatory bowel disease. Now, this is also true for colorectal cancer. When you look at the review and papers and studies on colorectal cancer, F. prausnitzii seems to play a significant role in colorectal cancer and possibly IBS as well. Then, of course, as you get the lower level of keystone strains, a lower short chain fatty acid and other postbiotic production, as we talked about, the next thing that goes wrong is the mucosal barrier. And the mucosal barrier disruption not only causes disruption because it is a physical barrier that prevents things from translocating, but it's also the largest sampling site. So the mucosal immune response is also another big factor. So I'll show you some studies there. This is a perspectives write-up. This is on the epithelial barrier, citing 3 big studies on this area where they show how the gut epithelial barrier dysfunction is involved in IBD, autoimmune disease, and systemic infection. They even go through very specific examples where pathogenic bacteria, if they are allowed to translocate past an intestinal barrier due to defects, they will translocate into lymph nodes and the liver, because now they're in the basolateral circulation. They have access to the enteric circulation. They can get into the liver, they can get into the lymph nodes through the mesenteric gland system, and in those lymph nodes, they will trigger systemic immune diseases like lupus. So allowing the translocation past the barrier systems is a big driver, and in many ways, the etiology of numerous conditions like autoimmune disease, IBD, systemic infection, and so on. And here's another very different condition than what we've been talking about. We've been talking about, inflammatory bowel disease, diabetes, cardiometabolic syndrome. Here's depression. How mucosal dysfunction, they talk about the intestinal mucosal dysfunction is characterized by an increased translocation of gram-negative bacteria. I'll talk about gram-negative in a second. And they name it leaky gut, plays a role in the inflammatory pathophysiology of depression. Right? If your average patient goes to your average allopathic doctor and says, hey, doc, how is my depression connected with my diabetes? The response would be they're not. One is in your brain and the other is because of your pancreas, right? Or how is my inflammatory bowel condition connected with my depression? Well, they're not. One is in your colon and the other is in your brain. Well, as it turns out, they are intimately connected. They are driven by the same root cause, the same systemic dysfunction in the barrier system of the gut, which starts with dysbiosis, ends up with a disrupted mucosa and mucosal response, and eventually a completely disrupted barrier system. And then, of course, there's other things, other seemingly unrelated conditions driven by the same thing. Take this, for example, gastroesophageal reflux disease, right? They find that the pathophysiology of GERD creates abnormal exposure of the esophagus to luminal content. So that's the translocation from the luminal content, which then leads to chronic mucosal inflammation, elevated IL-8, for example, pro-inflammatory mediators in the esophageal mucosa, and they show that eventually you get a destroying of the epithelial barrier function, which leads to gastroesophageal reflux disease, right? Reflux and depression and diabetes couldn't present more differently. They are, for all intents and purposes, unrelated conditions and would present completely differently. If a patient asks their standard allopathic doctor, how is my reflux associated with my depression, they would say there's absolutely no connection. As it turns out, it's the same root cause, the same thing driving the risk. And then we have other things like, for example, when you look at HIV enteropathy, which is a form of leaky gut barrier dysfunction, mucosal immune disruption, but it's really profound in HIV-infected individuals. They found that this severe mucosal immune dysfunction is associated with the progression to AIDS. So the conversion of the condition from just being HIV positive, which is the presence of the virus in the body, all the way to the acquired immunodeficiency syndrome, that progression and that change from a condition that you can live with for indefinite amount of time to AIDS, where you will succumb to it in some way or the other, is driven by mucosal immune dysfunction, severe mucosal immune dysfunction. And that is done consistently because of elevated expression of CD8 positive cells and innate immune response in the mucosa in the gut. And in fact, the NIH published a study, I believe it was in 2014, showing that the risk for mortality in HIV was better predicted by the rate of translocation, so the disruption of the barrier function in HIV patients and viral load itself, right? So in our words, leaky gut in HIV is the biggest driver of mortality versus even viral load, which is what they would normally measure before it sets up as acquired immune deficiency. So this is extremely important, tells a lot of tales. So there's lots and lots of evidence out there that many different conditions that are seemingly unrelated are driven by the same pathophysiology that we talked about, right? The same dysbiosis, the same reduction in keystone strains, the same reduction in important postbiotics and diversity, and then eventually a complete disruption of this trend of this barrier system and the allowance of translocation of compounds through. Now, one of the ways you can easily illustrate and explain this mechanism, how this particular ground zero dysfunction leads to all of these seemingly unrelated diseases, is by following the translocation of something called LPS. lipopolysaccharide, because one of the consequences of having this type of barrier dysfunction is that LPS, which is present in the lumen because it's made by gram-negative bacteria in the gut and other parts of the luminal content, other parts of the gut in the luminal content, and then also found in other mucosal tissues in the body, like in the respiratory tract, for example. This LPS is then allowed to translocate through and enter the blood, creating something called LPS endotoxemia. LPS normally is sequestered in the lumen, and when it's in the lumen and it's taken out and neutralized in the gut itself, there isn't a problem with it, but when it's allowed to translocate into circulation, it creates a lot of problems. So let's follow the role of LPS for a second. Right, so first of all, what is this LPS, this endotoxin? And note that it's called an endotoxin because it's a toxin that's generated from within the system. It's not something we can get away from as in an exotoxin, like a mold toxin. It is always being generated in our system. It is characterized by this fatty acid tail called the lipid A tail, and then of course it's got a carbohydrate core polysaccharide component at top, but it's predominantly a lipid, so it acts like a lipid in the body itself, and it's abbreviated LPS, term lipopolysaccharide. It's an inflammatory immunogen. It is probably one of the most profound inflammatory immunogens in the body, and it's part of the gram-negative bacteria outer cell membrane structure. Sorry, this shouldn't say cell wall, it should be cell membrane structure. Now, the bacteria use it for adhesion properties, example, to colonize parts of the host mucosa. It is part of the diversity of the antigenic part of this strain. It can be used for communication from bacteria to bacteria. So it has a lot of utility when it's sitting in the cell membrane of the bacteria. The moment it is released from the cell membrane because of bacterial lysis or bacterial dying, and it's free to circulate on its own, then it becomes a significant problem. It typically circulates at pretty low levels in healthy individuals. You can actually do a measure. We can't do this commercially, but you do this in the lab. You can do a direct LPS measure in a healthy individual with no conditions, and you'll find some baseline LPS level in the body. And that's fine because the body has a mechanism to deal with it, which I'll talk about next. But if the LPS becomes a spiked endotoxemia, meaning a significant rise in the presence of LPS in the circulation, that's when it leads to disease. And toxicity is mediated by this lipid A component, the fatty acid component of LPS. Now, what happens with immune activation when LPS enters the body? I mentioned there's something that your body is designed to have to deal with LPS, and that is LBP. This is so important and significant to the body that our immune system produces a protein that scavenges around the body looking for LPS. That's how important this singular endotoxin is. So we have this thing called LBP, LPS binding protein. When LPS runs into LBP, LBP grabs it, the LPS-LBP complex goes and binds to the CD14 toll-like receptor 4 complex on innate immune cells like dendritic cells and macrophages. That binding to the CD14 complex then triggers the release of NF-kappa B. When NF-kappa B is triggered, it then triggers this entire immune cascade, critical pro-inflammatory mediators like TNF-alpha, interleukin-1 beta, interleukin-6, and MCP-1. Those are the highlighted ones in most of this LPS-induced immune response. Now, and that's what's indicated here in the writing, so you don't have to necessarily read that. So this is a true innate immune response when LPS enters the body. The interesting thing about it is this exact pathology and pathophysiology has been studied for decades, but in the context of septicemia and bacteremia. This is exactly what happens to the immune response when you go septic or when you go bacteremic. And as we know, and any of you clinicians know, that's a very dangerous condition to be in. In fact, lots of COVID-19 patients are dying from septicemia or bacteremia, right? So your body knows this response, and this is the response that occurs when you have septicemia. It's the same thing that's occurring when LPS is allowed to leak through into your circulation every single day because your gut barrier system is dysfunctional. So you get a very measurable mini septicemia in your body every single day. Now, this is activated, and the reason it's called metabolic endotoxemia, it's predominantly activated during the process of eating and digestion. Right? You see the peaks of LPS levels in the blood, in the circulation, 5 hours postprandial. So every time you eat food, if your gut barrier is disrupted, you're going to get a 6 to 7-fold increase in the amount of LPS circulating in your body within 5 hours of eating that meal. That's why it's called metabolic endotoxemia, because it's associated with the metabolic process. We know we can't get away from eating food, and so unless our gut is healthy, the process of eating becomes the most toxigenic thing we all do every single day. And as it turns out, it matters some what you're eating, but just the act of eating itself causes this metabolic endotoxemia if your microbiome is not healthy and your barrier system's not functioning, right? So that's why it's so dangerous, because we can't get away from it. Right? It's not an exotoxin like having mold in your house where you might be able to move or remediate the house to remove the mold. This is an endotoxin that's present all the time. If your gut barrier is disrupted, every time you eat food, you're going to get a significant rise in the amount of this endotoxin and all of this immune activation to go along with it. This immune activation is what starts the process of disease driven by LPS. Let's go through some of those. So here are the clinical manifestations that are induced by the presence of LPS chronically in the system, especially when we're talking about this continuous spikes in the presence of LPS. First off, everything under metabolic syndrome, heart disease, dyslipidemia, hypertension, type 2 diabetes, dementia, cancers, polycystic ovarian, non-alcoholic fatty liver disease, all of these conditions have an etiology that is related to LPS endotoxemia or metabolic endotoxemia, also sometimes known as postprandial endotoxemia. So keep that in mind. Sometimes in the research, if you're reading into this, you'll see it written as postprandial endotoxemia. Sometimes it's written as metabolic endotoxemia or LPS endotoxemia. It's all the same thing, but everything under this metabolic syndrome spectrum is driven by LPS endotoxemia. Let's take a couple of them, for example. This is, and again, the American Diabetic Association is actually funding a lot of research into this area because we know diabetes is the next big health crisis that the world has to face. And in fact, Canny et al. Has published a number of studies showing that metabolic endotoxemia initiates the process of obesity and insulin resistance in diabetes. So it's the leakiness in the gut, the disruption of the barrier, the translocation and the presence of LPS in the circulation that leads to the formation of these measurable conditions, obesity and insulin resistance. And in fact, there are other studies that show that it triggers insulin resistance in an even more profound way than we knew before. It causes something called central insulin resistance. When LPS is allowed to enter into the circulation, it's a very pervasive toxin. It can get into many different areas of the body. Once it gets into the hypothalamic J&K region, it can elicit low-grade inflammation, thereby disrupting the brain's ability to read your blood sugar levels. And this is irrespective of body weight. Many of you may be familiar or even have firsthand experience of this, where nowadays we're seeing younger and younger people coming in presenting with type 2 diabetes. And we're seeing many of them being of normal body weight. So it's no longer the obese are at risk of type 2 diabetes because of continuous hyperinsulinemia and then the formation of insulin resistance. We're seeing this happening at younger and younger ages and with normal body types. And what they're finding is there's something called central insulin resistance, which means your pancreas is still working, your islet cells can produce all the insulin you need, but your brain cannot read your blood sugar levels. So that is really a profound issue. We also know from this really large CardioPrev study where they followed 462 patients for 60 months. These are patients that had higher risk for developing type 2 diabetes. Many of them were pre-diabetic category patients. They followed them to see which biomarkers were the most predictive indicators of the development of type 2 diabetes. In that study, they found only one biomarker that was 100%, nearly 100%, as close as you can get in these types of studies. It was the interval of confidence was over 95%. That could predict the formation of type 2 diabetes, and that was LPS plasma levels. Right? LPS plasma levels acting as a predictor of the development of type 2 diabetes. They did not find any other marker, things like C-reactive protein and obesity and oxidative stress and other things that they would have measured to be predictive outside of LPS plasma levels. So just think about how profound that is in terms of the effect of having elevated levels of LPS. LPS, of course, as we talked about, affects the brain. Here's a study from 2017 in September that showed that microbiome-derived lipopolysaccharide was enriched in the perinuclear region of the Alzheimer's disease brain. This is the best explanation for why the inflammatory response starts to occur in the Alzheimer's brain that eventually leads to tissue damage and beta plaquing, right? It's LPS from the gut that's traveling to that part of the brain, eliciting that inflammatory response that I showed you earlier. The same sepsis type of response that you get systemically is occurring in specific tissues, in the hypothalamic region of the brain, in the perinuclear region of the brain. It can happen in your joints in the case of arthritis, and so on. So this is a really profound thing that it can occur in regions that are very distal to the gut. We also know, take cancer cachexia, for example. This is a large study that was a follow-up to other studies, but they followed 152 colorectal and lung cancer patients, and they found that the level of lipopolysaccharide binding protein, so that's the LBP, they used that as the measure for LPS, was not only increasing cacatic mice and cancer patients, but also strongly correlated with serum IL-6 levels and predictive of death and cachexia occurrence in these patients, right? So cachexia, as a review, is that wasting syndrome. Most of you know that already, and we know that cachexia accounts for upwards of 60% of the mortality in cancer. It used to be thought that cachexia was driven by the chemotherapy and or changes in the diet in cancer patients, but they have found clearly that intestinal homeostasis in cancer cachexia occurs, and the disruption there occurs independent of any chemotherapy and food intake reduction, right? So it does not have anything to do with the chemotherapy or the food intake. They find alterations in the homeostasis are driven by barrier dysfunctions. And they point out that lipopolysaccharide binding protein as a new biomarker for cancer cachexia related to gut dysbiosis. So what they've shown in this study is that gut dysbiosis occurs, and in many cases it may be the dysbiosis existed before the cancer diagnosis itself, and that dysbiosis drives the risk for cancer cachexia, which is defined as LPS being present in high levels in the blood as measured by LBP, and that translocation then increases mortality rates among cancer. So this is how profound the presence of LPS and why barrier function is so critical. But again, this barrier function is driven by the same sequence of events, the same dysbiosis, the same reduction in keystone strains, diversity, reduction in mucosal function, mucosal immune response, and so on. And this is in cancer. This is the same thing in GERD that we showed you earlier. This is the same thing occurring in depression, same thing occurring in diabetes, and so on. This is even more relevant right now because people are talking a lot about obstructive lung disease as being a COPD as being a major risk factor for real adverse reactions to COVID. And what some of these studies have shown is that in addition to the presence of gram-negative bacteria in the lower airways, is a distinguishing feature of both a stable COPD and exasperated COPD. So gram-negative bacteria and their LPS being a highly potent pro-inflammatory substance seems to have an impact on the dose-dependent causes of fevers, chills, and bronchial constriction. So as the gut microbiome taxa shift occurs, when you have endotoxemia, it drives further dysbiosis. That further dysbiosis starts to affect what the microbiota looks like in other parts of the body, including the lungs as well. And then more studies have shown that lipopolysaccharide-induced endotoxemia in this is a mice study, extended the course of lung injury and repair and pulmonary fibrosis. So what they're showing is that circulating LPS has a huge impact on the health of our lungs. And so imagine if you've got a patient that has developed COVID-19 or has risk for COVID-19 like we all do, and we've got high levels of circulating LPS, that circulating LPS is going to drive continuous injury and dysfunction in the lung immune response. And then once a virus shows up, it's going to exacerbate everything. It can drive us towards this severe inflammatory type of response in the lung. And they even have done experiments where they show long-term intratracheal LPS exposure in mice leads to chronic lung inflammation and persistent pathology. And the persistent pathology is the pathology of chronic obstructive pulmonary disorders. So LPS plays such a significant role in everything. And this is just a quick summary then of other areas where LPS has been shown to play a role in driving disease. All of these have references. Of course, I can't put them all on this particular PowerPoint slide, but things like anxiety, chronic pain, because LPS can get into the dorsal root to stimulate something called nociceptors, which send out the pain signals. So you have all these patients with chronic pain in their extremities without any good explanation for where the pain is coming from. That can be driven by LPS. Parkinson's, next to Alzheimer's, are top 2 neurodegenerative diseases, also driven by intracranially LPS presence, driving microglial activation and neuron loss. Hypogonadism, low testosterone in men, driven by the presence of high levels of circulating LPS. Something called the gelding theory has explained this in numerous publications. Autoimmune diseases, of course, loss of memory and recall, because LPS can also get into areas like the amygdala and hippocampus, cause inflammation and disruption in memory there. Mood and appetite disorders, chronic constipation, which is very common in our world. We see people with gut issues because LPS disrupts the enteric nervous system. In fact, LPS gets into something called the dorsal vagal complex of the brainstem, which completely disrupts the communication between the brain and the enteric nervous system to turn on peristaltic activity and to turn on the migrating motor complex. This is a very major feature in SIBO, in small intestinal bacterial overgrowth, where stasis is present, and stasis is present in pretty much all SIBO cases. I think that's widely accepted. That stasis, in my view, is largely driven by the leaky gut that's also present in SIBO. The leaky gut allows LPS to translocate into the brainstem, causing this neurological disruption of the movement of the bowel. And the thing is, the studies that showed that also showed that you cannot turn the bowel back on even using prokinetics, as long as LPS is lodged there in the dorsal vagal complex. So we have to stop the endotoxemia and the LPS and the translocation in order to resolve issues like SIBO and IBS and so on. It becomes basic in our treatment of most of those digestive conditions. So again, to review, the process of disruption starts with dysbiosis, and this dysbiosis could start when somebody is 12 years old because they got a course of antibiotics for strep throat or ear infection or something like that. This dysbiosis then leads to low, which is then defined as low keystone strains, low diversity, leads to disruption in the amount of postbiotics, especially critical ones like short chain fatty acids. Eventually that leads to a disrupted mucosa. Then the next step is a disrupted mucosal immune response, because now you've got this massive translocation and influx of components in the mucin 1 layer into the inner sanctum. There's continuous inflammatory response in this area towards anything that enters, that eventually leads to a dysfunctional barrier itself, because the intestinal epithelial cells become disrupted and aren't regenerated in adequate amounts to keep up with the rebuilding. And then eventually you get too much LPS and other toxins, even things like flagellins and outside toxins, exotoxins entering into the system with a huge toxic burden, right? Of course, one of the organs that has to deal with all of this in large part is the liver. And hence we see LPS endotoxemia being a big driver of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. So there's a bunch of studies that show that as well, that LPS endotoxemia is likely the big driver of that condition. So it's a really profound pathophysiology that is at the root cause of seemingly unrelated conditions, right? That's the beauty of this. As we started to help our functional medicine docs and practitioners answer the question of what is going on with the depression gut, what is going on with the diabetic gut, what is going on with the autoimmune gut, we come to find out it's the same thing going on with all of their guts. How the disease manifests is dependent on other factors, perhaps genetic factors, other risks, lifestyle, and so on. But ultimately, at the root cause of the root cause, we have this disruption, right? So when we came across this and realized this, we said, okay, then in order to be able to fix the standard American gut and hopefully attenuate the risk for all of those things that we talked about, we have to systematically fix this common dysfunction. And to us, it starts with how the disruption starts. It starts with fixing the dysbiosis and reestablishing keystone strains, reestablishing diversity. Once you do that, then you can go about trying to fix the disrupted mucosal mucosal structure itself. Once the mucosal structure is reestablished, you will get an attenuation and fixing of the disrupted mucosal immune response. There are other ways to facilitate that as well. And eventually your gut, which is really designed to regenerate itself pretty quickly, will replace the broken down intestinal epithelium. And a lot of that is going to come from signals from this diversified new microbiome, right? So that became our focus. And so we developed this thing called the total gut restoration system. It became a simple 3-step system to go about fixing the standard American gut, the one that is driving all of these disease risks. And so it starts with step 1, which is reconditioning the gut. This reconditioning of the gut is really emphasized on improving the growth of keystone strains and increasing diversity. You start that with the megaspore, with the spore-based probiotics. We have shown in soon to be published and published studies that adding the megaspore alone has a profound effect on these keystone strains. But once you start making that profound change in the microbiome, you still have all of the forces in our environment that work against diversity. So things, for example, glyphosate in everyone's food and water, and environmental toxins, and just processed foods and antibiotics, antimicrobials, and so on. So all of these things continue to work against this increased diversity and increased keystone strains. So we said, as you started establishing this new microbiome, you have to reinforce that new microbiome by using a set of precision oligosaccharides that specifically feed the keystone strains. That's where the reinforce step comes in. So this is 30 days, step 1. Step 2 is a reinforce, where you're doing both the prebiotic and the probiotic at the same time. So you're reinforcing these positive changes. Then by the end of that second 30 days, your microbiome is measurably different. And now you can provide that microbiome the tools to rebuild the intestinal mucosa and start changing the intestinal mucosal immune response. I will very quickly in the next 2 minutes show you some studies to support this as well. But this is our total gut restoration. So month 1, you're doing this. Month 2, you're doing these two, the prebiotic and probiotic. Month 3, you're doing all 3. And by the end of that 3rd month, it's a great time to clinically assess the patient to see how they're doing, what improvements they've made. If they've made a significant amount of improvement and they just need to go on maintenance, I'll talk about what maintenance looks like. If they've made measurable improvement but aren't quite there, then you keep them on this round of all 3 for another 30 days. And then you assess again, and you do it for another 30 days and assess again. That's how you kind of go about it clinically to do that. Now, with the rebuilding stage, we found 3 really important components: immunoglobulins, polyphenols, and amino acids. And I'll just show you some quick data on that. This is one of the first studies we published on the modulations to the microbiome. This is data on both the reconditioning and reinforced state together. So this would be when you're doing the probiotic and the prebiotic together, how the microbiome changes. So we call it a symbiotic in our publication. So this is a typical subset data for individual. What we saw was a measurable increase in bifidobacteria. If these individuals' bifidobacteria levels were high, we saw a good measured increase. The lower the bifidobacteria level was, the higher the measured increase. In this case, the example I'm showing you is this person already had relatively high bifidobacteria, so we saw little less than 1 log increase, but still it was a measurable increase. When you look at that keystone strain, Fecalum bacteria, we're seeing a 2 log increase. 2 log means 100-fold increase in Fecalum bacteria. And mind you, this is in a 3-week period, right? This is not a long, prolonged study. This is just 3 weeks of the probiotic-prebiotic combination. We're seeing a 100-fold increase in Fecalum bacteria. Same with lactobacilli. We saw about 1.5 to 2 log increase, depending on where the starting levels were of this particular group of bacteria. And same thing with Akkermansia. This individual, as an example, had relatively low Akkermansia, and then we see upwards of a 2 log increase in Akkermansia where it is low in the descending colon, which is where you want to see the highest amount of Akkermansia. So a huge response in changing the microbiome the way it needs to truly repair dysbiosis. This is the entire cohort data. Same thing was seen in the entire cohort. Bifidobacteria, measurable increase. Most of the people we had in the study had relatively good amounts of bifidobacteria. This was a healthy, normal cohort. Lactobacillus was tended to be lower, but so we had a measurable of 1 to 2 log increase in that. Fecalum bacteria, same on average. People had around 10 to the 9. We saw an increase upwards of 10 to the 11 Fecalum bacteria, and many of the individuals had pretty good numbers of Akkermansia, but where we saw low numbers, we did see a high amount of increase. And if the numbers were good, it didn't increase. So it was a modulatory effect, which is really great. We also saw a huge increase in the production of postbiotics like short chain fatty acids, 80 to 140% increase in butyrate propionate acetate, as indicated here by these graphs, both in the ascending transverse colon and the descending colon as well. Then we also saw a huge measure in increase in diversity in the number of species now present at measurable rates, and to some degree the uniformity of the species as well. So we saw the luminal content in the colon increase dramatically using this index to measure diversity. We're talking about upwards of a 30% increase in diversity. So we're restoring the keystone strains, we're restoring diversity, and we're restoring the postbiotic production. That's going to have a profound effect on your patient's microbiome and total health outcomes, right? And this is going to happen for your patient if they're on the total gut restoration within the first 2 months. Now, the same oligosaccharides we use, I just want to show you some data. On their own, these oligosaccharides itself, like Livox, which is one of the ones we use, which comes from kiwi, showed huge increases in relatively short amounts of time in Bifidobacteria, Akkermansia muciniphila, Fecalum bacteria positizii, and so on. So lots of supportive data showing that huge increases are possible. This is why the IgG is very important. The IgG we use in here has been used in HIV enteropathy studies, showing the ability to improve duodenal function, change the mucosal immune response from an inflammatory response to a CD4 positive lymphocyte response, and promote actual repair of the gut lining, even in HIV enteropathy. This is why we jumped on this and said we have to have this in our rebuilding state, and that's why it's in the product as well, in the mega mucosa. They also have studies on pediatric ulcerative colitis showing the ability to reverse the UC index, meaning the level of damage in ulcerative colitis, just by using the serum-derived bovine immunoglobulins. So that's why this is so critical. They also show that it can neutralize and bind many toxins, including toxins from C. diff. And then they also have studies on binding toxins from mold and viral particles and so on. So it provides a really smart, intelligent binder to remove the toxic and immunological impact on the mucosa. Polyphenols become really important because polyphenols, especially the ones we use, have published studies showing reduction in inflammatory response in the gut. So stopping that LPS inflammatory cascade, blocking stress activation, protecting against things like experimental colitis. They also showed increase in butyrate production and reduction in calprotectin, indicating an improvement in barrier function. So this becomes a really important part of the rebuilding phase. And then finally, the amino acids, these 4 critical amino acids, we did not find them in any sort of rebuilding product. And they're so critical because they are the building blocks of the mucosal structure. these building blocks of the mucosa structure are absolutely essential in order to rebuild the mucosa adequately. In experimental studies where they damage the mucosa, they found that you get a 95% increase in mucin synthesis when you have these 4 amino acids present. So we want to make sure we're putting that back into the system, so your new microbiome, your improved postbiotics will have the tools that they require to rebuild the mucosa. And then finally, we want to stop that LPS translocation. We were able to show that even with just the probiotic alone, where we saw over a 60% reduction in LPS translocation over the placebo group. And that 60% reduction was in a 4-week period without doing any other interventions, right? And not only that, we also saw the reduction in all of the inflammatory markers that are significant with LPS endotoxemia, things like IL-6, IL-1 beta, MCP1, triglycerides, and so on. Using this heat map, we show you the 30-day post-testing for the spore-based group versus a placebo group. The spore-based group showed a significant reduction in all of those. So we are stopping LPS from translocating. We're reducing by a very significant measure the amount of LPS in circulation, even with a challenge meal, which is how this was done. And that has profound effect because we see that response being reflected in the immunological panel of these patients, right? So this is a total gut restoration. And a quick conclusion here for you guys, because I know I'm a couple minutes over time. Understanding the pathophysiology of the gut and the microbiome's involvement in disease is absolutely paramount to being able to treat it effectively, right? And diseases can be quite varied, and yet the gut-associated dysfunction is essentially the same. We showed how depression and GERD and diabetes, all these seemingly unrelated conditions, have the same dysfunction. This means that there is some degree of uniformity in baseline treatment for all of these chronic diseases. This equips you guys with real profound ability to change a person's microbiome for the better, no matter what the condition they are walking in the door with or getting online to talk to you with about. All of these diseases can be seemingly different. The other thing is, because this same dysfunction is at the root cause of so many conditions, when you're treating it for a particular condition, you are also thereby preventing further labeled dysfunctions that are associated with this disruption in the gut. So anytime you're treating this type of function in the gut, you are being both acute, you're addressing the problem at hand, but you're also treating it preventatively for anything that arises in the future. And I think that's why 4 out of 10 Americans have more than one chronic illness, because they have the same chronic dysfunction. So this is a total gut restoration. All of these products are available through Fullscript as well. We partnered with Fullscript a year and a half, almost 2 years ago, I think, to make these products much easily, readily available to our functional medicine doctors. And it's been a great relationship for us, so we're very excited to continue that relationship. But this is a total gut restoration. And again, you do month 1, it's 1 mega, you do the Megaspore. Month 2, you do the Megaspore and prebiotic. Month 3, you do all 3 together, and then you assess the patient. And then as the patient needs, you add all 3 1 more month at a time and continue to reassess. I mentioned I would say something about maintenance. Should your patient have profound change and they're ready to just be on maintenance, they don't have to be on all 3 of these every day. We always tell them to keep these 2 in their cabinet and maybe take both of them, once or twice a week. Some patients will continue to take the Mega Mucosa chronically because they feel it helps them so significantly with all of the variations in their diets and so on. But the biggest maintenance is doing this every day and then doing this once or twice a week. That's the standard maintenance. Of course, you can use your clinical judgment to assess and change that. But that's the end of my talk. Thank you again so much. And we promise, if you've put questions in the question box or in the chat, we will address them and send them back through Fullscript so they can get them out to everybody.